We are very glad to have you here to this first webinar of 2 that we organize within the Dentistry group of Universitas 21 with the University of Melbourne and with the Tecnológico de Monterrey. I'm Constanza Martinez. I'm professor at the Dental School of Pontificia Universidad Católica de Chile, and all of these 3 institutions, we are part of the U21, specifically from the Dentistry group, and we are so glad to have you here with us to discuss a topic related to oral health. And it's my pleasure to have here with us Dr. Rodrigo Mariño and the other panelists, Dr. Jorge Martinez from the Tecnológico de Monterrey, and my colleagues from Pontificia Universidad Católica de Chile, Rosario García, Claudia Vélez, Bruna Benzo, Sebastián Aguayo. It's my pleasure also to introduce you to Dr. Rodrigo Mariño, sorry, that he is a public health dentist, professor of population oral health at Melbourne Dental School, the University of Melbourne, where he has worked since 2004. He is Chilean, as you know. Rodrigo has dental degree from the University of Valparaíso, Chile, a Master Public Health and PhD from the University of Melbourne. Rodrigo's research is strong focus on oral health promotion and reducing inequalities in oral health status. He has established links and maintained continuous contact and research activities with major research and academics groups in Australia and overseas. Rodrigo has published more than 150 papers in scientific journals, several major research reports, and 36 book chapters. Rodrigo is currently the chair of the Dentistry group within the Health Science group Universitas 21, as I told you before. He was the foundation president, Oral Research Network from the IADR, and a member of the editorial board of the 3 international peer-reviewed journals. Rodrigo, he also been a consultant to the Pan American Health Organization in Washington, D.C. So Rodrigo, very welcome and many thanks, because we know that in Australia it's very late in the evening. So instead of you go to bed, you are here with us sharing your knowledge and stay with us, begin our day. So welcome, Rodrigo, and welcome everybody.
Thank you very much. Thank you for your kind introduction. Actually, well, I should thank you for organizing this. I know that organizing these webinars is very challenging and require a lot of organization and patience with for everything to happen. And you're right. Here is 11, well, past 11 p.m. in the night. It's a Friday, so. If I weren't here, maybe I would be somewhere else. So don't worry, I would be awake anyway.
Thank you very much.
Okay, well, today's topic is about oral health in migrants, dilemmas, challenges, and solutions. And this is a topic that is very relevant in Australia, but I would say that in any country is very relevant because the migration has increased in the last few years. And also the importance of the and the visibility of other minorities within each modern country are getting more visible. But before we start, I would like to acknowledge the Wurundjeri people, who are the traditional custodian of the lands where I work and live. I would also like to pay respect to the elders, both past and present, of the Kulin Nation, and extend that respect to other indigenous Australians. This is the main campus of the University of Melbourne. This is one of the campus. There are several, and this is based in Melbourne. This is we call the city, like the downtown Melbourne. And here, just to use this picture, this is where the Australian Open is played every January. not sure if this January will be this January will be there, but will be sometime in summer. And if you can see here, I don't know if the details are good enough, there is a lake here. And this is Albert Park, where the Australian Grand Prix is run in every March. So going back to the campus, this is the main campus. The dental school is located here. This is a dental hospital. So theoretically, we are off campus, but it's just crossing the street and you are in the campus. But even though it's not very far away, usually dentistry try to traditionally dentistry isolate to the rest of other health sciences. So that cross is a very significant one. Crossing the street is a very significant one because it's about integration of oral health to other health disciplines and to other disciplines, professional disciplines. And this is the dental hospital. And my office is in this corner, in the 5th floor, but I haven't been there since March, so I hope I'm still there. They haven't moved. The hospital and the school has been closed. Well, not closed, but it was very difficult to gain access. Now we are getting the pandemic is very under control here. But I still haven't been there. So students are coming back to practice, but I haven't been back there. You have to ask for several permissions and go through forms to certify that you don't have any condition, etc. So I haven't been there. Okay, so this is the general overview of what we are going to cover today. It's about culture, what is culture, why it's important, what is being culturally competent, and why culture competence is important, and how we can achieve and assess cultural competence. To start, there are 3 characteristics that we all have. And sometimes they tend to be used as synonyms, but they are not. And those are race, ethnicity, and culture. And race is the classification by the physical characteristic, and that is transmitted genetically, so we have no control over that. The other characteristic is ethnicity, which is the sense of the shared sense of belonging based on characteristics such as common religion, language, ancestry, national or geographic origin, and or other cultural attributes. Now, ethnicity is something that I assign to myself. I can self-assign my ethnicity. And the other characteristic was culture, which is defined as an integrated pattern of human behavior that include thoughts, communications, languages, practices, beliefs, values, customs, rituals, manner of interacting, roles, relationship, and expected behavior of racial, ethnic, religious, and social group, and the ability to transmit the above to succeeding generations. In other words, culture is reflected in everything that is not natural, nature. So everything we do is part of our culture. Now, so as I said, these are 3 characteristics. They are different, but sometimes they are used as synonyms, but they are not. Now, when another related concept is acculturation, and that is the changes, is the process of change that somebody from coming from one culture of origin moves to another culture. So theoretically, it goes in two directions, but when somebody belonging to a very small, to a large receiving society and a small in-group, the changes will be more in one direction. But theoretically, the model works bidirectionally. So acculturation refers to the process that involves an accommodation to the host culture on the part of a member of a migrant culture. Now, the process of acculturation takes place into two dimensions. One is behavioral, and the other is psychological. On the behavioral dimension are all the external aspects, like language, clothing, food, and social contacts. And the psychologically are more in-depth element of that culture in terms of norm, core values, beliefs, and attitudes. And we can change behavioral, or we can acculturate behaviorally very fast, or well, if we want, pretty fast, and learning the language, changing clothing, adapting new foods, and changing social contacts. But the psychological dimension is more profound and more difficult to change, and at the same time more important for our purpose, for health. And this is the model. A migrant first has to be a contact. If there is no contact between the migrant and the receiving society, there is no acculturation. So contact must happen, and it's basically impossible that somebody from a migrant does not establish some sort of contact in the receiving community. And that contact will be mediated by the individual characteristic and also by the receiving society characteristic in terms of age, gender, education, religion, place of residence, it came from rural areas or from urban areas, health status, etc. All that will influence this process of acculturation. And also the receiving society characteristics such as multicultural policies, ethnic policies, immigration policies, etc., will mediate in this transition. Now, when somebody is faced to an environment that is completely different to the original, well, not completely different, there are some different, there will be some changes, and those changes could be physical, biological, political, economic, cultural, social, and behavioral. And physical, for example, if you come from a very big city or very crowded and migrate to a place where there is no, in rural areas, for example, there will be different population, different crowded buildings will be different. This is all the social or the physical aspect of that change. Biological, there will be exposure to new germs, for example, new diseases. There will be intermarriage, could be also. Political, somebody coming from a very powerful situation, when migrate, that power may be reduced. Economic changes, when we go, when they some professional, when they migrate, they cannot validate their titles, so they have to do other jobs, and that will have economic implication, cultural implication, probably the most obvious because there are some different, and social changes that will change the type of power, social power that somebody may have. Now, when somebody is faced with changes, there would be a conflict. I mean, this conflict could be minimal or could be big. And what we do as a living being, when we have a conflict, we try to reduce that conflict, and to reduce that conflict, we move toward that challenge to modify ourselves to reduce the conflict, or fight against or resist that conflict, or if that conflict is too big, we can move away and don't try to interfere, so to reduce the conflict. Now, from that conflict will be an outcome. Depending on which strategy we use, we will have an outcome. And the outcomes of acculturation are six, but there are four dimensions. One is integration, where I adopt new elements and I keep some of the element of my original culture. So I integrate, I am part of that, adopting new elements and keeping previous element or from my culture. The other one is assimilation, when I become similar to the receiving society. So I relinquish to my original culture to become similar to that. The other one is separation, when I decide, or a migrant decide, that doesn't want to communicate with the receiving society. And when the opposite, when the receiving society doesn't want to receive this newcomer, is called segregation. So separation and segregation are the same, depending on who make the decision on that. So I separate if I don't want to join the receiving society. And I am segregated when the receiving society doesn't want me to be part of that. The other one is marginalization, when I don't want to become part of the receiving society, and also I don't want to keep contact with my original culture. So I'm marginalized. And when the decision is made by the receiving society, it's called ethnocide. So these are the four outcomes: integration, assimilation, separation, and marginalization. And depending on that outcome, there will be more or less contact, and this is a cycle that never ends, and there is no endpoint to which a migrant, of the acculturation process. There is never a migrant is fully acculturated. The process finish is always a cycle, continuous cycle on that. Now, as I said, there were two dimensions: behavioral and psychological, and the strategy that I can choose for each of the elements of within the behavioral dimension and within the psychological dimension will depend on my strategy. So I could be, integrated with some elements, but for example, in language, I keep both languages. But in terms of food, for example, I just want to eat those of the receiving society. So there are different layers and different levels and different strategies that a migrant can use, depending on how much contact I want to keep from my original culture and how much I want to adopt from the receiving society. So why culture is important in terms of health? Because our cultural background are filters to process new experience and process events in our life and information that we have. Culture will influence people's value, actions, and expectation, and we said this psychological dimension. And also we have an impact in the perception and expectation to the other. If we, as a health professional, ignore culture, individuals and families are at risk of not getting the support or the services that they need, and that could be very harmful and could be and will have some health effects. So that's why we need to consider culture when we provide health services. And these are some examples of how the ethnocultural context will influence health and oral health. First, within the family and the in-group culture of where I belong, seeking health services and utilization of health services, etiological views of health and disease, the patient and health professional interaction and relationship, communication and language, and then acculturation and health. And in terms of family and in cultural group, family is, well, culture is very important to the family, and the family, that culture will decide when we want support, from whom we want support, and how we ask, we approach and get that support. In terms of etiological views, this is the WHO definition of health as the complete state of physical, mental, and social well-being, and not merely the absence of disease and infirmity. And this is our Western understanding of health. But there are others etiological views that are as valuable as this one. In general, the etiological views of health and disease could be biological, which is more related with the WHO definition, but also could be mystical, that my health or diseases and health condition are due to punishment for my sins or sins of my ancestors. Magical etiological views that health and disease are due to things like Ebelai or other intervention, animistic, that ghost and they have an influence on my health. And the other etiological views are environmental, that, for example, there is a moon effect or some or the sun effect on my health. So all these are the etiological views. We, as Western or more influenced by the Western approach, we adopt this one, but there are other. I mean, we are mostly this, but also this, we have some mix of other explanation of why things happen. Even though when you say something, you knock good, and that's a type of magical effect on things. So even though we have this more scientific approach, we still have this part that say, well, there is something else that may be influencing what happened. And as an example of this is the Maori culture. From the Maori culture, they have a view of the whole person, and they have different levels of health. And there was a very interesting study about the Maoris in general. They have well, some of them are overweight. They have a high pressure, high blood pressure, and other chronic conditions. And there was a study that asked them, do you know which are the risk factors for high blood pressure? And I said, yeah, of course, it's your diet, the lack of exercise, alcohol, smoking, etc. So they knew all the risk factors. And then they asked them, what do you think is the main health problem of the society, of the Maori society? I say, the main health problem is the destruction of the family. That now we don't have this ancestral in-group element. So it wasn't that they didn't understand the message, the health message of and the theological understanding of diseases, but the priority and the health view, which is more holistic, for them the problem was not, the health problem was not the hypertension, but the destruction of the family. So that's why an example of how the culture may change when we ask for help, to whom and to what condition. Well, of course, also there is this the patient health professional. In some culture are more vertical, to others more hierarchical. So the expectation is that the health professional is the one who will tell me what to do, and I will not challenge that opinion. But in other culture, they say, look, to the health professional, look, tell me what I need to do, and that's it, and I will do the rest, because they have a more horizontal approach. So that will be mediated by the cultural background, and of course the language and communication will influence. Now, acculturation and health. Acculturation was that process of change that the migrant go through when getting in contact with the receiving society. And we did a study with the Vietnamese community here in Victoria. The Vietnamese community is one of the largest non-English speaking migrant groups in Australia. Still, most migrants are from countries like New Zealand, or the largest group of migrants are from New Zealand and from the UK. But from those that do not speak English, the Vietnamese, the Chinese community, and also the Italian and the Greek are very large in Australia. So we did this study in the Vietnamese community in Richmond, which is one of the suburbs of Melbourne. So we wanted to assess or describe the relationship between acculturation, dental caries history, and visit to the dentist in Vietnamese background participant, 18 years of and older, living in Richmond, which is a multi-ethnic suburb of Melbourne. And well, we did the questionnaire with the acculturation scale, and then the conventional oral health assessment. And these are the results of the dental caries history. So overall, the group has a DMFS of 27.8. Those who were, there was the first, this is the decision tree analysis, and the decision tree at each node separate into subgroup according to the p-values. So this is how we analyze this. It's a sort of a multivariate analysis, but the difference is that at each node, all the variables come in linear regression. When one variable is significant, it doesn't continue in the process. Here, laborer was again here, for example, in this node. Or in this one, so it's a bit different. So the first split was between laborer student and against those not working or not working outside home. Then this group, laborer and student, were split by psychological acculturation. And remember, psychological acculturation is about norms, values, beliefs, etc. And we measure the acculturation against the receiving society, which is Anglo-Celtic in Australia. So for this score that we have here, if they have a score 0, is the mean of the Anglo-Celtic society. And we measure that using the instrument, the acculturation scale. So if they were low acculturated, this is minus 4.7 to minus 2.3, they have low dental caries. If they have high psychological acculturation, from minus 0.82 to plus 136, remember 0 is the mean of the Australian receiving society, they have low DMF, low dental caries history. Those in the middle were the highest. So the shape of this is like an inverted U. Low acculturated, low caries experience, high acculturated, low caries experience, those in the middle, high caries experience. And then this group was split again into lower than 35 years and older. Remember that DMFS is increased with age. So there was another split. So the interesting point here is that this effect, this U-shape effect, and this is important because in general, in some description of acculturation is described as an only increasing result. While here we demonstrate, or we obtained as a result, our finding was that the shape was an inverted U. So we interpret this as those who are low acculturated, they keep the protective factor of the original culture. And those who are highly acculturated, they adopted the preventive messages from the receiving culture. But those who are lost in the middle, they may have lost the original culture factor or protective factor, and still have not adopted the receiving society protective factor, were those who have higher dental caries experience. Then for those not working outside home, 34.04 was the DMF. Then the next split was by age. Remember, DMFS is a cumulative index, so increased by age. And among those younger than 35, behavioral acculturation was relevant. And those who were low behaviorally acculturated, this is about, behavioral acculturation is about language, food, and external aspect, had a higher DMF, dental caries experience, as opposed to those who have a high or medium behavioral acculturation. And again here, we interpret that those with low behavioral acculturation may have changed the diet, but they didn't have the skills to understand the message, the health message. So they adopt some elements, but not all the elements, and that put them at more risk. And this was about a visit to a dentist. And this is very interesting because overall, 42.1% reported a visit to a dentist in the last 12 months. Now, the first split was by age, and those who were younger, they reported less visit to a dentist as opposed to who were older. Then, those who were certified and older, the next split was the proportion of their life in Australia. So time in Australia, but we didn't use a number of years, but proportion of life, because somebody who is 20 years old and have been in Australia for 5 years, the proportion of life is bigger or larger than somebody who is 50 years old and have been 5 years in Australia. So that's why we didn't use a time of exposure, but proportion of life of exposure. And those who have a lower proportion have a higher proportion of visit to the dentist, or those who visit to the dentist in the last 12 months compared to those who have the longer exposure. So if we stop here with the years of exposure or proportional life of exposure, we would conclude that those who have more time in Australia have less or tend less to go to the dentist. But then we included the psychological acculturation. And here we found that those who are highly acculturated, remember, 0 is the resilient society, so -1 to +1, 72.7% have visited the dentist in the last 12 months, while those who were low acculturated, psychologically acculturated, show the lowest proportion of having visited the dentist in the previous 12 months. So if we don't incorporate acculturation, we would have come to the wrong conclusion, because this group is very similar to this one. I mean, 70% to 72%. So they're very similar. But this group is the one who is pulling this proportion down. So this is the group that we should target with awareness campaign for dental visits. And if we can identify where this group meet, we can better target that or who they are, the socioeconomic or socio-demographic profile. We can identify exactly where we should put our efforts and resources to get the outcome that we want. But again, if we don't use this psychological or acculturation variable, we would have come to the wrong conclusion. So what is cultural competence? It's defined as the integration and transformation of knowledge about individuals and groups of people into specific standards, policies, practices, and attitudes used in appropriate cultural setting to increase the quality of services, thereby producing better outcomes. So being culturally competent will produce better outcomes. It's also another definition is the ability to effectively operate within different cultural contexts, or the ability to think, feel, and act in ways that acknowledge, respect, and build upon ethnic, sociocultural, and linguistic diversity. So this is the definition of cultural competence. So who is responsible for this? We're all responsible for this. I mean, the government at all levels, at the federal level in Australia, or at the central government, at the regional level, provincial level, at the municipalities, and also at the health services. Policy decision-making has to, in all agencies, has to develop those guidelines. And this is not just for health, has to be at all levels of government. Managers also have the responsibility to create culturally competent organizations, professional bodies like the Australian Dental Association, the Chilean Dental Association, Mexican Dental Association, to promote culturally competent policies. And practitioners, individuals, also are responsible for that. So we are all responsible to create culturally competent services. So do we need, why do we need that? Because well, first, because it's, everybody has a right to healthcare, and this is a human right. As I said before at the beginning, diversity is increasing in every country, and sometimes health systems are not always responsive to this increasing, and some groups experience health inequalities more than others. and also because health services by law are responsible and accountable for meeting the needs of their consumers. And there is pressure to improve the Bank Charter for Health Promotion and the WHO Health Report. They also have talked about the need for this cultural competence. The benefits: improve equity and access for all groups. It's a good business practice, more effective service for health consumers and carers, better use of health resources. And so that's I tell to my students, look, if you train yourself or acquire cultural competence, you will have better business. You have a better business practice. You will rewarded economically for being like that. So there is a financial benefit on being culturally competent. So a culturally competent health system acknowledges the benefits of diversity, achieve the best care for each consumer, ensure that self-determination of consumer is respected, and holds government, health organization, and managers accountable for meeting the needs of the community they serve. And this is important because it's not only that they have right to access or equal access to services. The important thing is that all groups, all members of the community get the same outcome. And this is different than having just equal opportunity to access. And that's why this is where culture and other elements, of course, are very relevant. Now, how do we develop culturally competence? And this is the model by Wells, I think it's Marcia, her name, and that was published. She developed the model and established different levels of cultural competence, starting from incompetent to arriving to culturally proficient. So in her model, there are the 6 stages that are divided into 2 phases. The first phase is cognitive phase, and require the acquisition of knowledge of the dimension of culture, generally and specifically for certain groups. And the other one is the affective. It required the professional experience interacting with those patients, as well as investing and committing to cultural diversity. So in the first, in the cognitive phase, we start with incompetence, then we go to cultural knowledge, where you know that there are aspects of culture that other individuals may have, and they have, and that culture have a role in behaviors. Then the next level is cultural awareness, where I recognize and understand that those practices may have an impact on what I do. And then the affective phase is cultural sensitivity, when the professional have knowledge and awareness of cultural and integrate those elements into the professional practice. Then cultural competence, when culturally appropriate practice are incorporated routinely in the practice. And cultural proficiency is the ability to integrate cultural competence through one's repertoire for scholarships, including practice, teaching, and research, and mastery of all stages. Of course, it's very sophisticated stage or complex. But cultural competence at the individual level, at the practitioner level, is more than being tolerant to other cultural groups. Is the ability to identify and challenge our cultural assumptions and our values and beliefs. Well, it's about, as an individual, as a practitioner, it's about developing empathy and connected knowledge. The ability is also the ability to see the world through the other's eye, or the other of the patient, and at very least to recognize that other may view the world in different ways. As human, what we tend to do when we face something that is unknown or less known, we apply previous knowledge. So we use stereotypes to classify people that we don't know. And that is okay, because this is our first approach to something that is unknown. But then we need to reflect on that stereotype and challenge the stereotype with evidence. And again, I mean, the important point here is through the world through other eyes. I mean, and try to understand why somebody does what she or she does. So a culturally competent individual is likely to possess a strong knowledge of how one's own culture shapes attitudes, perception, and behaviors, valuing the diversity and willingness to learn about other people's culture, have a specific knowledge of language, custom, values, and of particular culture. Of course, there are so many languages and so many specific cultural group that it's impossible that an individual get to know all the languages and customs. A culturally competent individual also possesses the skill to feel comfortable and communicate effectively with people from diverse cultural backgrounds. And a culturally competent individual possesses an awareness of the limited value of stereotyping individuals from certain culture or ethnicities. A culturally competent organization is about, remember, culturally competent is at different level. A culturally competent organization ensures that that there is a commitment to cultural competence that are seen through all the levels of the hierarchy, should be reflected in the philosophy, in the mission statement, in policies, the structure, practice, etc. And in information, how information is published and disseminated, and advocacy for all cultural group that they serve. There are some system factors that would be mediating in that process. And one of them, and probably the most evident and basic, is the language. And language has been cited as a problem for many patients. The other issue is the unfamiliarity of the system. Remember that we said at the beginning that a migrant coming to a resilient society will experience changes, and then this is one of the changes where decisions are made in different ways. And what was known and accepted in the original culture is different here. I remember when I first came to Australia. We drive in the left side, and not only we drive, we walk also, or tend to walk in the left side. We do everything in the left side. So I remember when I was here a few weeks, I went to the swimming pool, the public swimming pool, and I started swimming. I was swimming in the wrong side because there was these lanes to swim, and I was putting my culture, my previous knowledge into a new situation, and wasn't effective. Or when I was climbing the stairs at the dental school, I was running in the other side, and I bumped into people coming the other direction, because that is part of the culture. And the other anecdote that I have, and also this was when I was here a few weeks, I went to a meeting in one of the hospitals, and after that I went back to take the train. Here in Melbourne, there is no subway. But there is a train system, but it's in the surface. So I went to the train station, and the train arrived. And because I was in the meeting, was maybe, I don't know, 6:37, was not rush hour. There was I think there was nobody in the station. So I was the only one, and I coming from Chile, and in Chile, the metro, the subway, open doors automatically, and you enter the car. But here, you need to open the door. The door will not open automatically. But because I was working in the assumption that I have from my culture that the door would open, I didn't do anything, and the train left because I don't know, the driver interpreted I didn't want to take the train, so the train left. And then I understand that I start learning that you have to open the door. And in other times, when there was other people in the station, they opened the door because I was still keep waiting for the door to open itself. But then you learn start integrating your knowledge, and you learn that you have to open the door. So that is an example of how previous knowledge is not effective in the new environment. So again, this is somebody who go to the health services and have the knowledge of how health services work in the country of origin may not apply on how things work here. As a matter of fact, the Australian and the Chilean health service organization is very similar because they are both based on the British National Health Service. So the organization, when I first came here, was not for me was not very different to what I was used to be. But in other countries could be different. But again, I mean, a migrant may face unfamiliar system that they don't understand, and that make them not to access those services. This is part of another study that we did with Greek, Italian, and then another one that we did with Chinese. And this is how they rank the barriers that they have to access dental care services. And this is for the Greeks, for example, the first barrier was the time waiting for appointment. But for the Italian, well, and the Chinese was the cost. For the Greek, the cost was not a barrier. But for the Italian and Chinese, it was a barrier. And the other one here, waiting for appointment, I mean, was important, but not that relevant. Transportation is different for different groups. So not all the members, migrant groups, are the same. They are different. And even within a particular migrant group, not all the members are different, are the same. They are different. So they may experience a situation or have different or more specific barriers and problems than others. So why is important with oral health? Because as we said, there has been a significant increase over the last 50 years, and each country are becoming more ethnically and culturally diverse, or if they already were diverse, this culturally ethnic and cultural group are getting more visibility. And for example, in Australia, there are new legislation at different levels of government that make illegal to discriminate. So in a perfect health care system, all this issue of age, gender, race, sexual orientation should be blind, should be provide the same type of services to anybody, and the same, and each member of the community should expect to get the same outcome, health outcome. How are we going? Well, it's not much left. So the role of the health provider, again, is become sensitive to that there are some cultural difference in terms of belief, tradition, experience, ritual, languages, etc. And the oral health provider and the health provider in general must be competent and multicultural. Understand, have some knowledge of, cultural knowledge and cultural awareness, and avoid ethnocentrism, as in the sense that believing that my approach is the right one and I have to impose my ideas to other cultural groups. This is about cultural awareness. Again, definitions. Cultural awareness entails the understanding of how a person's culture may inform values, behavior, and culture and beliefs. Recognize that we are all shaped by our cultural background, which influence how we interpret the world around us and perceive ourselves and relate to other people. So avoiding that we are the point of reference and we set how other people have to behave and feel or believe. Again, the emphasis here is that no individual can be reduced to a set of cultural norms. We are all unique and different. So as I said before, within any cultural group, there are differences. There will be difference, culturally different also. So a cultural awareness, you have to be aware of how your own cultural influence your decision, not judge people's behavior and beliefs according to the standard of your own culture. Be aware that not making assumption or a generalization to individuals, because I said we are all unique and different. And understand that people may change. Through this process of acculturation, and some people and some members of the community, and even in some families, there could be differences. Now, communication, as we said, is the most common or the most obvious challenge. And if we fail to communicate, we can create misunderstanding, but also will create a lack of trust and increase anxiety levels on the patients, and we will not producing the best outcome. And this is about a language. I don't know, well, if any of you know this, but I'm pretty sure that you all understand the words here. You understand what red nose is, and you understand what reclaim the night is. But this has different meanings. Red nose is, there is a red nose day here, is for awareness and money and raising money for sudden death of babies. And reclaim the night. Yes, for sudden death of baby, and reclaim the night is about stop violence. The reclaim the night is that anybody can, men and women can go out in the night and enjoy going out without any threat of violence. So, you can understand the words, but unless you have the cultural background, you will not understand the meanings of these words. So that's an example of how words are more, communication is more than words. So if there is a problem with the language, you will need to use an interpreter, and the interpreters are trained to do that. Don't, in Australia, at least, it's not encouraged to use family members, or to use somebody who speaks the language in that organization, because that may create some problem. Because, for example, a family member, and you are collecting history, and because it's a family member, may hide some information that could be relevant for health purposes. So you have to use the professional interpreters when needed. Well, we are going to move fast here, and remember that we have verbal communication and also non-verbal communication, and that is change in different culture. Gesture that we do may not be acceptable for other, or may mean something different in other. Physical contact in general in Latin America. In Latin culture, we touch people, and it's very normal. But in other culture, they are less used to touch. Eye contact is a difference. How we listen also is different. Somebody may not look at your eyes when you are talking, and that is not a sign of disrespect or anything. It's just a cultural element. So we need to check all these elements in our patients. Yeah, and this is another thing. I mean, to dress properly, because if we don't dress in the formal uniform and the type of shoes that we use, the patient will not accept or be less or more reluctant to accept our health advice, because the health professional are seen in a way that doesn't fit that the dress that somebody may have. There is also some sex preference of treatment. A male patient may prefer to have a male practitioner, so we need to ask for that. Again, don't assume, ask first. And punctuality also is time is have different values in different cultures. Time expectation in some groups also is important. So we need to emphasize that, so we don't miss the appointment. I remember once there was a practitioner that he said, I don't know why this person came late, and I don't know why he came. I mean, I couldn't do anything, and I said, look, maybe this person came because value you and respect you. So that's why he came, even though he was late. So you can look at the different from a different perspective, and you can have a different reaction and solution. Holidays, again, not all the culture follow the Christian calendar, so and they may have implication for treatment. So we need to be aware of that for appointments also. These are examples of how culture may influence communication and interaction, and that interaction will have effect in the effectiveness or quality of our care. And if we want to be a culturally competent oral health provider, we need to become familiar with the predominant group in our community. I mean, as I said, you cannot cover all the community, but you can get some information on the predominant group in that area. So yeah, and because it's more likely that you have effective multicultural interaction that will have some benefits for the service and also for the care that you will provide. There are some use in some cultural groups that are unusual in Western culture. For example, betel nut chewing, which is it's cancerous. A risk factor for cancer is a cultural issue. Is in Southeast Asia, but countries that have a large migration from those countries may have that situation there. Well, we will talk about a little bit about this is more emphasis on the same oral hygiene practice. This is the point. Oral hygiene practices are again central to any culture, and is culturally mediated. And we use toothbrush and toothpaste with fluorides and all that. That's part of our culture. But other culture, they use different other things for oral hygiene, and also to treat oral conditions that we must be aware. And again, we should try to avoid paternalistic or maternalistic approaches, because those could be ethnocentric and trying to tell the patient what to do, as opposed to understand why somebody is doing that. The Chinese medicine, there are some practices also that may influence or interfere with the treatment, because the explanation that you may give is not consistent with that traditional practice. These are the miswak twigs, and this type of stick are present in this. It is in the Arabic world, but this is present even in South America, in Latin America. That cultural group use this special stick to convert them in. They chew the tip, and it converts into a sort of brush, and they use that for brushing. And in some countries, it has a religious connotation that we have to be aware. Other oral hygiene practices use different kind of powders and elements to clean the teeth that may have some oral health implication, but we need to be careful how we introduce that knowledge or change that behavior. Also, there are many mutilation, soft tissue mutilation, like tooth avulsion, that may have a cultural meaning, alteration of the shape of the crown, lacquering and staining of teeth, use of decorative inlays and crowns, tattooing, facial scarring, uvulectomy also, or tattoo of the tongue, tooth or canine bud removal, because it's thought that is healthier to do that. And this is practiced in different parts of the world as a cultural element, sign of bribery, or marriage, a female, or to indicate that somebody is married. So we have to explore this in terms of which culture or which group are we more likely to be in contact. And this is from Central America, the old Mayan culture. They use this they change the shape of the tooth, and this is not for cavity preparation, but for ornamental or hierarchical practices. And this is the black lacquering of the tooth in females. It has been described as in Vietnam, but it's in other parts of Asia. and also is being abandoned. But it's very interesting because it's a sort of sealant that they put in all the crowns of the tooth, which is black in color, and they have no cavities under, and they put it when they are young, and they stay forever, for life. And we think of a sealant that you have to replace every few years. This was more effective. And I read once how they put it, and it's a sort of acid etching, and then they put other elements on that. But again, it's a tradition that is being lost because the new generations, they don't follow that. And to end, I have this word of Octavio Paz from the book Labyrinth of Solitudes. And he said, what sets the worlds in motion is the interplay of differences, the attraction and repulsion. Life is plurality. Death is uniformity. So when we talk about understanding culture, knowing culture, this here is talking about demanding diversity more than accepting or knowing or being aware of a diversity, because that gives more possibilities to solve problems. When we are alive, we are different. When we're dead, we're all the same. We're uniform. And on that note, I will finish. And thank you for your attention. And I'm happy to reply any question that you may have.
Thank you very much, Rodrigo. It's very interesting, your presentation. Right here in Chile, we have a lot of diversity right now. And this is a very, very interesting topic for us. So anybody in the panel has a question for Rodrigo?
Yeah, here.
Go ahead.
Hi, Rodrigo. Thank you very much for this interesting presentation. And also thank you for sharing that beautiful picture of Melbourne Uni. Well, I know that in Australia, a lot of work has been done in relation to the integration of immigrants, even in relation to indigenous people.
Yep.
Here in Chile, these issues have been introduced more recently. So from your experience, what do you think that would be the main challenges for us as a school to introduce these topics to students?
Well, this is something that should be, and we are working on that. We're going through a curriculum review, and this is one of the issues that should be. It's not something that you do in first year in 1 hour and that's it. It's something that should be embedded in the curriculum and go through the whole training of practitioners, of students. The challenge, as I said, and also as the practitioners, is to again challenge our assumptions. I mean, that understand that there are other worldviews that are as valid as ours and should be considered when making a decision, and avoid ethnocentrism and impose our values in a maternalistic or paternalistic way to our patients. But again, I mean, if you are interested in training, is something that should be embedded in the whole curriculum, and not only embedded with elements, evaluated, because that we saw that. I mean, if something is not evaluated, the students will not pay attention because they concentrate in completing the program and do the number of filling and number of prosthetic appliances. But because this type of communication skill and cultural skill are not evaluated, they don't care. And I understand that it's very difficult for students that are in a very well, I mean, they are students, so they don't have the confidence to do things with the patient because they are being trained for that, and they don't know all the procedures well to establish that rapport. So and for somebody who is from a different culture in Chile and in most parts of the world, sport is a ice break issue. So you talk about sport. Did you see the game on Saturday? And that's a way to start talking. But if somebody from a different culture, I have no idea. Look, I've been living here for more than almost 30 years. I still don't understand the cricket to start, or the Australian road football. I have no idea. So if somebody talk to me about that, I will not be able to respond. So it's very difficult to establish that rapport with somebody who has the same cultural background that you have. But that could be trained in the school and provide some scripts so a student can go and break and understand and challenge those assumptions, stereotypes and assumptions.
Thank you, Rodrigo. We are a little out of time, but we have time for a couple more questions. In the panel, someone have another question for Rodrigo?
Maybe somewhere there, no? in the QA.
Yes, in the QA we have two questions.
Okay. Yep.
The first one is from Bruna Benzo. Considering a multicultural country, can we point particularly elements that are effective to lead a positive oral health outcome?
Well, I would say that, well, as I said before, I mean, try to understand why people do what they do. I mean, what is the meaning, the cultural meaning of what they do? Avoid overimposing our own values, because that will create a break and will impede the communication and will have or it will interfere in our treatment. As I said before, there are some cultural very hierarchical, so they will say yes to whatever you said in the interaction, but when they go home, they do what they want, because you didn't break that. Your message didn't break the cultural barrier. So I don't know if there is any element that is common to, I mean, of course there are elements, general elements that are common to all culture, but you have to work and use your cultural knowledge to apply to different groups to achieve that the best possible oral health outcome. So yeah, there is no one fits all kind of answer here.
Yes, it's difficult. So we have another question by Paulina Humedes. Paulina, do you want to speak to do your question? Paulina.
Okay. You are listening? Are you listening?
Yes. Yes. Go ahead.
Good morning. Thank you very much for your interesting speech. I'm working through communication skills and cultural approach, I think the last 10 or 15 years. And now my PhD thesis is about this kind of interesting and how you can engage with your patients by communication skills and using the framing theory, like you build reality through the frame you have as your own culture. And I'm focused this research in children, how you can improve this kind of clinical working and patients in the earliest years. And I want to know if you have some experience or if you know something about how can you understand and address this approach you share with us today when your patients are children and mostly they are invisible in our policies and our teaching, looking children like us, they are somebody that they have to obey our orders instead of listening what they can say about their healthcare.
Are you working with any particular group, or?
I'm working with 6 and 8 years old, and I'm going to do a deep interviews with dentists, children.
No, but which cultural group?
Chileans.
Ah, okay.
Okay, because I want to know, first of all, I want to know how children, as Chilean children, understands their interaction with the dentist and the clinical setting. And with this understanding, can I give some communication approach to engage them in their oral health care, understanding their culture, their oral health culture.
Yep. Well, I suppose the culture and knowledge that they have is the one of the family, and I would say that particularly the mother. So probably the approach to get there is to involve the family in the process. I don't know if that answered your question.
So we are on time right now. So thank you very much, Rodrigo, for your excellent presentation. As I told you before, it's a very interesting topic for us right now. And I don't know if someone in the panel or you want to close this webinar with a couple of words.
If not, I can say something.
Yes.
Well, this is a topic that fascinates me, so that's why maybe I extend too much. And as you said, and Paulina also I think mentioned, or Rosario was, in Chile is increasing. In the past, the cultural diversity was, I mean, compared to other countries, maybe it's still low, but it has increased a lot in the last 10 or 15 years. And so that makes more visible the need for cultural competence. But in some part of the country, and maybe some parts of in Santiago, they concentrate these groups. In La Araucanía, for example, is about 35% of the population, and the patient base are from a different cultural background. And maybe in some neighborhood in Santiago also receive more migrants, and so those working in those migrants should be in those neighborhoods should be aware of those of the cultural base of the community. So it's something that is increasing. Here in Australia, one out of 4 people that you see in the street, one was born outside Australia, so it's very relevant here. But in any country in the world, this is relevant. So thank you very much, you for inviting me. And as I said, this is an area that fascinates me. And I am available if anybody wants to send me any question after this, or wants to keep the communication, please feel free to contact me.
Okay, thank you. Jorge, do you want to say something?
I just wanted to thank you and congratulate you, Rodrigo. Great presentation, very interesting. Thank you very much.
So thank you, everybody, to being here this morning, and see you next Friday with the second webinar. And have a good night.
Excellent. Yes.
And thank you for your effort.
Yeah, I will be there next Friday. So.
Okay. Bye-bye.
See you next Friday. Bye.
Thank you very much.
Bye now.
Thank you.
Bye-bye.